I'm going to talk to you about the TRACE study. What we're looking at is peanut thresholds in allergic reactions. We're also looking at the effect of sleep deprivation and exercise on allergic reactions too. So what I'm going to do is talk to you a little bit about the background of the study, what led to us looking into this, and also about extrinsic factors as well. So I'm going to talk to you about what an allergen threshold is, although Hazel's done this most excellently in a talk before, and just update you a little bit on our study. So what is an allergen threshold? Well, a threshold is generally defined as a limit at or below which a stimulus causes no reaction. Now, if we translate this into allergy, when we think about allergies, it's actually the amount of protein that's required to provoke an objective allergic reaction in an individual. Why are these allergen thresholds so important? Now, Hazel's alluded to this before. Currently, when managing peanut allergy, the main strategy is to avoid the allergen because there's no cure available for peanut allergy. A lot of my talk today is focusing on peanuts specifically because this is my area of research. Despite avoidance, though, accidental ingestion still occurs, and it's a major cause of severe allergic reactions. And this causes a major burden on allergic consumers' lives. It impairs their quality of life, and I'm sure you're going to hear a lot more about this in the next talk. So how do allergens end up in foods? Well, there are two main ways. Firstly, it can be deliberately added as an ingredient, and actually the labelling that governs this type of deliberate addition of ingredient allergens to food is really quite good. And there's been changes to the legislation in December that's made sure that the presence of any 14 allergens must be labelled in bold. So here on the left you can see the old style of labelling where it's not clear as to where the allergens are, with the new style of labelling where they're highlighted in bold. Now, what we're really interested in with TRACE is the second way that allergens end up in food, which is by accidental contamination. So food allergens can end up in foods accidentally. For example, when food manufacturers share production lines to produce food, then allergens can end up in foods just by contamination. Now, the labelling that governs this type of accidental contamination is entirely voluntary and is at the moment extremely inconsistent. So you see loads of labels that say may contain traces of nuts, made in a factory where nuts are processed, not suitable for nut allergy sufferers, and these are the bane of food allergic sufferers' lives. So, and also studies have shown that there's actually little relationship between these precautionary labels and also the presence of actual allergen in the product. So what food allergic consumers do is they can go one of two ways. They can either just ignore these labels completely because they just don't know how to take them and they put themselves at risk and they basically just eat all of these foods. Or they can go to the other extreme and they can really follow these labels to the letter and really restrict their diet and restrict their quality of life. So why are these labels that govern accidental contamination so rubbish? Well, there's actually real uncertainty about the lowest levels of allergen to which allergic sufferers react. We don't know the proportion of allergic sufferers that react to a particular dose, and we also don't know the relationship between allergen dose and severity for any individual. So it follows that the smaller amount of allergen that you're exposed to, the more mild your reaction will be. But in the papers, there's been reports of people having severe reactions to small inhalational amounts and also to traces. But we just don't have the information on that. So how do we overcome this problem? Well, a way that we can do this, as Hazel said, is actually try and measure people's threshold. And that's what we're trying to do in a TRACE study. And these, so we've got lots of threshold studies that are available at the moment for us to look at. And most of them are in children, not many are done in adults. Information can also come from immunotherapy studies like Andy's and also diagnostic food challenges. So what we try and do is we glean all of the information on thresholds of individuals from these studies and we put them all together, and what we'll aim to do in the future is try and model a population reactivity threshold, i.e. we'll try and find an amount of protein that will not cause a serious adverse reaction in the majority of the population. And this will give us the ability to measure and control control levels of allergen in food, and it also will reduce the risk to consumers by improving allergen labelling. So how do we work out somebody's threshold, and what do we know about thresholds already? Well, we know that somebody's threshold lies between a no observed adverse effect level, which is the highest amount of allergen that does not produce a reaction, and their lowest observed adverse effect level, which is the lowest amount of allergen that produces a reaction. And studies on peanut thresholds have found that these vary by about 4 to 5 orders of magnitude. So some people might react to milligrams, other people might react to thousands of milligrams. Why is there so much variation? Well, we think because lots of studies vary in their protocols and also challenge matrices. So as I said, we're going to try and get this information on thresholds and produce a population threshold. We're trying to produce what we call an eliciting dose, where in a population threshold where the eliciting dose refers to the dose of allergen that produces a response in a certain proportion of the allergic population. And somebody called Steve Taylor has done loads of work on this already, and he's found that the ED10, which is the amount of protein that elicits a reaction in 10% of the population, is about 3 milligrams of peanut protein. So in 90% of the population are actually okay with this amount of protein. But we need further work on this, and this is what we're aiming to produce, this kind of curve in the TRACE study. But what's really interesting to us in TRACE is that thresholds can also vary within an individual as well. So we get patients that come to us in clinic and they say that they think that their allergic reaction changes over time. And indeed, studies like this one have shown in sequential challenges that actually there might be a 10-fold change in threshold between challenges. But why does it vary? Well, you can think about this in 2 ways. So it might vary because of individual factors that are pertaining specifically to that person. So their asthma control, the severity of their previous reactions, any comorbidities, their age, or any concurrent medication or hay fever. But also, there's external factors or extrinsic factors like sleep deprivation, exercise, alcohol, infection that can also modulate allergic reactions. But we don't know very much about these at the moment. But they are playing a role, because this is a summary of the prevalence of cofactor-induced anaphylaxis, and you can see this is global. These are global studies. You can see that exercise can play a role in up to 16% of reactions, alcohol in about 15%, infection, even things like hormones having some kind of effect. So as I said, we're trying to model this dose distribution curve for peanut allergen thresholds, but we're thinking and hypothesizing that actually exercise and sleep deprivation might either lower the threshold or increase the severity of a reaction, and they might shift this dose distribution curve to the left. Now, so why did we get interested in thinking that exercise can affect an allergic reaction? Well, really, because there's no data on how and why exercise augments an allergic reaction. We do know that exercise can play a role in food allergy from data on a clinically distinct condition, which is called food-dependent exercise-induced anaphylaxis. In this type of condition, people under normal circumstances can tolerate wheat, for example, but when they eat it and they exercise, then they can go on to have full-blown anaphylaxis. And there's 2 postulated mechanisms as to why this occurs. Perhaps it's that exercise can increase the bioavailability and distribution of allergens, but also that the threshold for activation for mast cells, which are the cells involved in an allergic reaction, can be decreased by exercise. And in this study by Matsuo, they found that when that immunoreactive gliadins actually appeared in the serum of wheat allergic patients when they were challenged with wheat and exercise, but not when they were just challenged with wheat alone. So exercise is having an effect somehow. And why is it having an effect? Well, we think maybe that people's intestines become more permeable when they're exercising. And this was shown by Pals et al., not specifically with allergens, but they measured the excretion of of sugars in the urine pre and post exercise, and they found that indeed small intestinal permeability was increased after they exercised them at a really high intensity, 80% of their maximum exercise capacity. So gut is becoming more permeable. And what's the science behind this? Well, we think that when you exercise, your blood is diverted away from your gut to your major organs involved in exercise, your muscles, your heart and your lungs. You get a little bit of relative gut ischemia that causes some damage to your gut epithelium, that then causes some inflammatory mediator release and disruption of your cellular tight junctions, and also the allergen is then liberated into your bloodstream. So greater amounts of allergen can get into your bloodstream. This is a postulated mechanism but needs to be proven. Why did we get interested in looking at tiredness in the TRACE study? Well, in the study that was led by Andy Clark in immunotherapy, they found that patients, when they entered their maintenance phase of immunotherapy, actually lost tolerance to peanut allergen when they took their peanut doses if they were particularly tired or sleep deprived. So that actually sleep can lower their reactive threshold. So that's why we became interested in looking at this. So I'm just going to talk to you now about the TRACE study and what we're doing. So we've taken two of those extrinsic factors, sleep deprivation and exercise, and we're measuring how much of an effect they have on peanut allergy thresholds and reaction severity. So this is a multi-centre crossover study. We're doing it in Cambridge. We're also doing it in London as well. We're recruiting 100 peanut allergic patients aged 18 to 45 with a history of a systemic reaction to peanut. And what we're aiming to do, what objectives we've put out for the study are that we're trying to get a dose distribution curve like the one I showed you before for peanut thresholds, where we're going to produce the first data in a UK population. We're going to define the variability of threshold and severity of reaction over time within individuals. And we're also going to establish how these extrinsic factors modulate responses to peanut and what degree. And we're also going to look at those individual host factors that I was telling you about, exercise and age and asthma, to see how they modulate reactions. So what are we doing? So we're recruiting the patients. So we get them into the study. We determine whether they're peanut allergic by doing taking a history, doing skin prick tests, blood tests, and then what we do is we get them in on a baseline challenge to ascertain what their threshold is. We then randomise them to receive a further 3 challenges, which are spaced 3 months apart, and this is with exercise, with sleep deprivation, and just a repeat of their baseline challenge. And those can come in any order. So when we test their threshold, we basically give them peanut in the form of peanut flour. This is what Hazel was talking about before. So it comes in the form of a matrix. The first challenge, baseline challenge, is double-blinded, placebo-controlled. So on one day they have the active challenge, the next day they have a placebo challenge. And this is the matrix that it comes in. So it's this awful chocolate mousse that the patients seem to like, that doesn't look very nice. We start at really low doses, so 3 micrograms of peanut, and then they're given a series of 8 doses spaced 30 minutes apart. And what we need to do is we need to establish criterion as to when we call a threshold and when we stop the challenge. So we have to score and stop the challenges based on certain symptoms, which I'll show you in a minute. So what they have to get is 1 red symptom, which is a severe symptom, or 3 concurrent yellow symptoms. So we use a traffic light scoring system, and these are modified from the Practile guidelines. So we spent quite a long time modifying these criteria to make the challenge really safe, because obviously we're giving people peanut when they're allergic to it. So this is how we score and stop challenges. This is how we decide when somebody has reached their threshold. So basically, green symptoms are mild symptoms. So for example, oropharyngeal itching, or a little bit of subjective chest tightness without any falling pleat flow. And it's across all organ systems, as you can see. Yellow symptoms are a bit more severe, and when patients develop these symptoms, I exercise a bit more caution with proceeding to give them more doses. And then we've got red symptoms, which are a definite no-no, and we stop the challenge immediately if any of those appear and treat. We treat with all the routine things. We've got a whole armoury of stuff that we keep drawn up and ready for patients. We do it in a very safe environment as well. And I'll talk to you about what we see in the challenges in a second. So how do we do the exercise challenge? Well, what we do is we repeat that where we give the series of 8 doses, but after, what we do is we give the dose, and after 5 minutes we do a bout of 10 minutes of exercise at 85% of their maximum exercise capacity on an exercise bike. So they have to progress through each dose and exercise after each dose, and we stop when they react. In the sleep deprivation arm of the study, patients get admitted to the ward the night before. We give them 2 hours of sleep, and then the nurse has to keep them awake all night. And then we get a lot of grumpy patients in the morning, and we give them peanut on top of that and make them have an allergic reaction. But despite that, they all seem to come back and enjoy it. So that's how we do their sleep deprivation challenge. And then the third challenge is just where we just repeat their baseline. So what are we going to get out of this study? Well, we're going to get, as I said, reaction thresholds in 100 individuals, and the effect of extrinsic factors, as I said. But also, what we're doing is that we're going to, what we've done is we've asked patients to actually describe in detail about how they feel and their symptoms were by giving them a visual analog score. So we've really got a lot of data on how they feel in an allergic reaction. And Hazel alluded to this before, but we've had some really interesting symptoms which are really common amongst patients. So a lot of them do describe being depersonalized and having that weird kind of feeling where they feel completely out of it. So we've got really fine-grained detail on their symptoms, which is going to be really interesting. We're going to have an exact relationship of dose to reaction severity, and we're going to also see how they've tolerated treatment. We've used adrenaline a lot of times, and I'll go into this, and how patients have tolerated adrenaline as well. So I can't give you any data because we're midway through the study, so I'm just going to give you some examples of patients having a challenge and what symptoms they get. So you can see that patients, when they're given dose 1, dose 2, dose 3 and dose 4, they get all these minor kind of green symptoms where they get a little bit of itching in their mouth and feel hot, but they are always transient, they go away, so then I proceed to give them the next dose. So then we get to dose 6, and here in this patient you can start to see that after about 3 to 5 minutes they get this itching again. 20 minutes later they get face erythema, they get wheals on their legs, and they start to get nauseous, lots of loose stools, they get itchy hands, and their scalp starts itching, and then a lot later, 78 minutes later, they start to have difficulty swallowing. So with this patient, obviously I gave them adrenaline and hydrocortisone and antihistamine, and that was a very clear threshold at dose 6. So that's 100 milligrams of peanut protein. And I want to just demonstrate to you what changes we've started to see with exercise here. So you can see that in this baseline challenge that we had for the patient, they got all of these little green symptoms in the first few doses, and then at dose 6 again they start to get tummy ache, hives and runny nose, so that was a clear threshold. I gave them oral treatment just to stop it, and they recovered quite quickly. Now look what happens when we exercise them. This is really interesting. So they start to get all these green symptoms to start off with again, and then when we get to dose 5 they start to get a warning sign of feeling a little bit lightheaded, so I left the dose a little bit longer, that resolved. Gave them dose 6, and then they started to feel sick very quickly, itchy palms, runny nose, and then they started becoming red from head to toe, started to get chest tightness, they got this sense of impending doom, so I treated them with adrenaline quickly, antihistamines and steroids. So here you can see that exercise, although it's not lowered the threshold, it's increased the severity of their reaction. So exercise is having some kind of effect on this patient. And look what's happened with sleep. So that's produced some interesting results as well. So basically no symptoms really in the first 4 doses, and dose 5 they get abdominal pain, they get a bit of nausea, then dose 6 they start to get chest tightness, a fall in their peak flow and erythema. So I treat them with everything: antihistamine, steroids, adrenaline, nebulizers. And then when we apply the sleep deprivation and we get them back, you can see that their threshold is lowered. So their symptoms all start kicking in at dose 5 with nausea, abdominal pain, throat tightness, and their wheeze. And actually his allergic reaction was a lot worse this time with greater respiratory symptoms. So he was treated adequately, and you can see that sleep deprivation seems to be both increasing their severity, but also lowering their threshold too. So that's going to be really important, factoring in these extrinsic factors into modelling thresholds. So you can see in the examples that I've just given you that we've been using adrenaline quite sportingly. So we use it in about 29% of cases, and this is just a comparison from the rest of the literature. So we're comparable to this recent study by Noon, but it's a lot higher than these other studies to the right. But there's lots of determining factors as to why this adrenaline usage is variable. Well, I mean, we know we're doing a high-risk study where we're giving peanut allergic patients peanut, so we've got a lower threshold for using adrenaline compared to other diagnostic food challenges. Also, this is in adults. A lot of those other studies are in children, and it's my experience that adults seem to follow a more severe phenotype. And also it's dependent on how jumpy the investigator is as well. So I mean, even in myself, I can see, as I've seen more and more cases of anaphylaxis, I've certainly changed the way in which I use adrenaline actually. So that's been quite interesting. These are the main indications as to why we've used adrenaline in our patients in Cambridge. Obviously there's a London side as well, but I'm just presenting our data in Cambridge. So mostly it's always been for respiratory difficulty, persistent cough, falling peak flow, wheeze, in the majority of cases. Thankfully I've only had one case who became hypotensive, and I used adrenaline in his case. Once for laryngeal edema, and we have a lower threshold for using it in these other circumstances, so erythema and profuse repeated vomiting, because I just wanted to switch the reaction off. And also, if I've got the sense that their reaction is progressing very quickly, I'll give adrenaline, and we've had to do that in a few cases, and I'm glad that I did. So this is some more data. Basically, we've had 3 patients out of, however, I think we've done about 200 challenges. 200 challenges or so. 3 patients have required 2 doses of adrenaline for reactions that haven't stopped after the first dose. I've also found that I've used nebulized adrenaline in 3 cases, and I found it really useful actually as a bronchodilator when salbutamol hasn't worked by itself. Also, just it really gets to the site of action, and also when patients have had a swollen throat, it's been really effective. Now, subjectively, what have patients reported? They've reported that after having adrenaline, they felt better within minutes. Typically, they've reported that the main symptoms they've said are that they get shaky, they feel that their heart's racing, but generally it's really well tolerated. And the types of patients who've required adrenaline have required it on each successive challenge that they've come to. So, and they've been happy to have it again. You know, they haven't been put off by having it the first time. Cardiovascularly, it's well tolerated. All that we've seen really after giving it is just mild rises in their systolic blood pressure and heart rate. We did have one patient who, after I gave them adrenaline, they reported that their heart felt a bit weird. I checked an ECG, and indeed he'd gone into having some junctional ectopics, but they reverted spontaneously after an hour or so. And he was a patient who, like I showed you on a previous slide, who'd had hypotension. So I don't know whether it was that had precipitated this rather than the adrenaline itself, but that's important. This is an important case to look at as well. So where are we with the study? Well, we've recruited 100 participants. We've completed 50, and we're estimating that we're going to finish the whole study in July, and we're hoping to publish in later this year or early next year as well. We've got preliminary indications that actually there is a clear trend that's emerging on the threshold dose of peanut protein. We're finding that there's a constellation of patients that are reacting at a certain dose. So this is going to give us really interesting information for food policy makers. And we're also showing that extrinsic factors seem to be having an effect either by increasing the severity of a reaction or lowering a threshold dose. So this is going to be really good data that will come out. So I hope I've run you through thresholds and how they vary across the population. I hope I've shown you that exercise can play a role by interfering with GI absorption, and shown you a little bit about our study as well. Thank you everybody that contributes to this study. There's loads to mention here, but thank you so much for everybody taking part, especially the patient.
Thanks very much, Shelley. Any questions?
Sorry.
Yes, Lorraine.
That was fascinating. Thank you so much. I had a few questions, but one of them relates to... Thank you. I might have missed it when you originally put up how you did the study and the challenges. What was the gap between the two challenges, the sleep deprivation and the other? And the other part to that question is, did you cross them over at all, just in case having done the order in which they're done, or the exposure in any way affects?
Yes, so 3 months, we do them 3 months apart, and it's a crossover study. So patients are randomised to receive those 3 challenges in any order. So so they are in different orders in different patients, so that we can see if there is indeed an order effect as well. Yeah.
Thank you. And the other was just, I was interested to hear a bit more about the patients that required the second dose of adrenaline and what their stories were.
Yeah, of course. So the first patient was the patient with the hypotension that I told you about. So he basically had dose 5 and then started to feel quite weird and started to feel a little bit dizzy. His blood pressure dropped from 130 to about 100 systolic. So I gave him adrenaline then. And then he recovered, but then started to cough about an hour later and developed severe generalised erythema. So I gave another dose of adrenaline at that point, just to switch the reaction off, and he needed it. I've excluded him from the study. He was too severe. And then another patient had very severe generalised erythema, and then just persisted with respiratory symptoms that didn't respond to bronchodilation, so she needed another dose of adrenaline and nebulized adrenaline about 2 or 3 times before she settled. Yeah, and yeah, that was it. The third patient was one of our very first patients, actually, and I think I was being a little bit jumpy in giving that second dose of adrenaline because it was one of my first. He developed late onset generalised erythema. I could probably have treated that with antihistamines only, but I gave it to switch the reaction off.
Thank you. We also noticed some dissociation between the patient's view of the severity of the reaction and the investigators. Do you want to say something about the visual analog scores and the more severe reactions?
Yeah,
that was interesting.
Patients didn't really, because they were in a safe environment having this challenge, they really didn't, even though I perceived I needed a drink after quite a few of the challenges. And they basically said that they just had a moderate type of reaction, and I was ready to not come back to work the next day, and I had rated it as very, very severe. So yeah, there's a big discrepancy between two, so it's going to be really interesting to see how patients feel.
I think environment might be a really big
Absolutely
factor
right,
there,
yeah.
because I think when you're in a safe environment, it's like when you're feeling really poorly, as soon as you get home,
Yeah.
you feel within your environment, you feel better, and I think probably because they're in a safe environment, if they had that reaction out somewhere,
I think you're right.
they'd have probably rated it differently.
Yeah.
Could it be also for some people that they don't worry so much about their environment and they don't rate their severity as that great when they're out in the field? I'm just thinking of people who don't use their adrenaline auto-injector.
Yeah, they're probably, if they're people who aren't going to take their adrenaline out with them, they're probably reducing down how bad they think they feel to justify the fact that they've not got their adrenaline with them. Oh, I'm fine, I don't feel too bad, it's not a bad reaction at all. I didn't need to bring my adrenaline with me. So sort of rationalise to themselves that it's not a very strong reaction.
Are you getting expecting them to administer their own pins in that situation?
No, because obviously, you know, like the maximum dose is 300 micrograms, and we give our own adrenaline. It's all drawn up, but I will train the patient when they go home, so that they make sure that they know absolutely how and when to use their adrenaline auto-injector. And they've reported actually they feel a lot more confident having seen their own allergic reaction. It's given them a lot of information about when it's appropriate to use an adrenaline auto-injector, so that's good for them.
Okay, no more questions. Thanks very much, Shelley. Well done.
That's okay.